Hello, everyone, and thank you for joining us today. Welcome to the 2025 American Diabetes Association's Living with Diabetes Ask the Expert series. And today's topic is No Diabetes by Heart. I'm your host, Susan Weiner. I'm a certified diabetes care and education specialist and a registered dietitian nutritionist. Our Ask the Expert series is all about you and what questions you'd like to ask, so please start to get your questions ready about today's topic, No Diabetes by Heart. This event will be hosted in English as well as in Spanish. So if you're joining today by phone and want to participate in the Spanish version, please press *0, that's *0 now. If you're joining today by phone and would like to ask a question, which I know many of you have, please press *3, that's *3 on your keypad, and an operator will come on and collect your questions and place you in a queue so that you'll have the opportunity to ask your questions live during today's broadcast. If you're participating online, please type your name and your question in the field below the streaming player, and remember to hit the Submit Question button so your questions will come directly to me and I can ask them live on your behalf. And stay tuned throughout the entire hour. We're going to have such a lively, great, and informative conversations and provide you with great education and tips throughout to help you live well on your journey with diabetes. And in addition, at the very end, we would really appreciate your feedback on a short survey. It helps us plan for future events, so please stay with us. By joining our program today, you're taking a great step towards taking care of your health. And because of the link between diabetes and heart health, the American Diabetes Association, in collaboration with the American Heart Association, has launched No Diabetes by Heart. They were able to do this with the support from founding sponsor Novo Nordisk, and the No Diabetes by Heart initiative provides tools and excellent resources for people living with type 2 diabetes to learn how to reduce the risk of cardiovascular disease. As part of this initiative, the ADA is hosting today's free educational Q&A and will cover information and tips to help you take charge of your health. When you live with diabetes, it may increase your risk of heart disease, stroke, and kidney disease. So please make sure when you see your doctor or your healthcare provider, you talk about heart disease risk and work towards prevention. Please visit nodiabetesbyheart.org for more information and resources. And now it is my great pleasure and my privilege to introduce today's incredible guest expert, Dr. Michael Medema. Dr. Medema is the Director of Cardiovascular Prevention at the Minneapolis Heart Institute and the Medical Director of the Nolan Family Center for Cardiovascular Health at the Minneapolis Heart Institute Foundation. He did the majority of his medical training in Minnesota, but completed his training in Boston, Massachusetts, with the Cardiovascular Prevention Fellowship at Brigham and Women's Hospital, as well as obtaining a master's in public health from Harvard T.H. Chan School of Public Health. He started his position with the Minneapolis Heart Institute in 2013 and is currently the Director of Cardiovascular Prevention. He was a committee member for the 2019 ACC/AHA guidelines for the primary prevention of cardiovascular disease and is a current member of the American Heart Association's Diabetes Council and is the team cardiologist for the Minnesota Timberwolves. Welcome. We're so excited to have you with us today.
Thank you for having me.
So glad that you're here, especially super excited to have you here during Heart Month. It's great. So to kick off our discussion, can you start by telling us what is the link between diabetes and heart health? Why is knowing how to reduce your risk for heart disease so important for a person living with diabetes?
Yeah, it's incredibly important. You know, there is a very strong link between diabetes and cardiovascular health for a couple of different reasons. Number one, it's very clear that diabetes is a risk factor for cardiovascular disease. So having elevated blood sugars puts stress on the vessel walls, and it makes atherosclerotic plaque more likely to build up. And so it's a direct link to risk for coronary heart disease, for blockages in the arteries that feed the heart. But it's also a risk factor for heart failure, for the heart pump not being able to keep up over time, as well as a risk factor for stroke and peripheral arterial disease. So having diabetes increases your cardiovascular risk very clearly. We also see they have a lot of shared risk factors, meaning the things that develop diabetes also put you at risk for developing cardiovascular disease. So an elevated weight, higher blood pressure, these things kind of overlap with risk for cardiovascular disease and risk for diabetes. And so if we look at overall health in people with diabetes, quite often the thing that affects them the most are cardiovascular complications. So not necessarily the diabetes itself, but the cardiovascular disease that comes in part because of the diabetes. And so one of the main things we want to do if we see somebody with diabetes is say, how can we adequately address their cardiovascular risk?
It makes so much sense when you explain it that way. And I think our discussion today, we're going to get into some of the nitty-gritty of how we can reduce our risk of cardiovascular disease and how we can improve our heart health. So thank you so much for that. As a reminder, if you're just joining us, welcome to today's Ask the Experts Q&A. Our topic is No Diabetes by Heart, just perfect for Heart Month. And as a reminder, for those of you who are joining by phone, please press *3, that's *3 on your keypad, and an operator will collect your question and place you in the queue so that you'll have the opportunity to ask it live. If you're participating online, please type your name and question into the field below the streaming player, and remember to hit the Submit Question button. And if you're joining today by phone and would like to participate in the Spanish version, please press *0, that's *0, so we can take your questions. So we have a number of questions already coming in, which is very, very important. And let's see. Let's go with this one first. We have a great question coming in from Eva, and Eva is calling us live. So Eva, please go ahead with your question.
I have been diagnosed with heart disease, enlarged heart, irregular heartbeat, congestive heart failure. What can I do to not progress this any further than what it has been? Is oxygen a good premise to use all the time?
Gotcha. Thanks for the question, Eva. It's a very important question. Like we just talked about, having diabetes definitely increases your risk for congestive heart failure, for the heart pump not being able to keep up over time, which makes people feel short of breath when they do stuff. It makes swelling in the legs. It clearly affects their quality of life. And so, like treatment for diabetes, actually, the treatment for heart failure is very clearly best when it's a multifactorial approach, when it's not just one single treatment, but yet a multitude of different things. And so when we approach heart failure, we want to get rid of the excess fluid that's built up. So quite often that requires some diuretics. But that doesn't necessarily prevent the heart failure from progressing. That's just kind of a treatment to make people feel better. The things that really prevent the heart failure from progressing are medications that can protect the heart, of which there are several. Good treatment of the diabetes, the better the blood sugars are under control, the less the heart failure tends to progress. And then also the lifestyle part of this is always very, very important. You know, a healthy diet, including a diet that's low in sodium, is really important for heart failure. And also plenty of physical activity. That's probably the one thing we've learned the most. You know, 50 years ago for heart failure, the recommendation was always to rest and take it easy and not stress your heart out. Turns out that's probably pretty bad advice. That's not the right advice at all. And so the nice thing about the physical activity research is that it doesn't take that much. So even little bits of activity can help. As far as the oxygen goes, the oxygen can help people feel better, and it can keep their O2 sats up. But again, that's not necessarily an underlying treatment. That's just kind of allowed a kind of symptomatic improvement. Really, the treatment of the diabetes and the treatment of the medications to help protect the heart, those are the things that can help the heart heal over time versus get worse over time.
Okay, that was such a great response, because I tell people sometimes you have to think about getting a prescription to not exercise. So that was such a great response about physical activity. We used to think that lying around and taking it easy and resting and just not moving off the couch was the way to go. But you're absolutely right. Movement, physical activity is so very important in prevention, isn't it?
It is. And I think sometimes the mistake we make in the modern era is that a lot of people look at the medication part of this and the lifestyle part of this substitutionally. Meaning that we have some people that really don't want to take any of the medications, and so they're just going to work really hard at taking good care of themselves. And taking good care of yourself is fantastic. Obviously, it's an essential component of the treatment, but it doesn't necessarily take the place of the medications. Some of these medications have been very clearly shown to improve heart health over time. and with a relatively low side effect profile. A lot of these medications are quite safe. And so if you look at the people that do the best in this situation, it's people that take good care of themselves combined with the appropriate medications that your cardiologist and endocrinologist prescribe. It's that combo together that does the best.
That's so true. We have a great question coming in online from Glenn. And Glenn is asking, what's the deal with taking some of these GLP-1 medications for weight management? Are they really for weight management? Are they for diabetes? Are different of those medications for both? And how does that intersect with heart health and preventing heart disease? Or does it?
Yeah, that's a great question, and one that I'm very interested in, and one that we should definitely spend a little time on. So I'll try not to go too long, but it's a very important topic right now and a very hot topic right now. So GLP-1 is a glucagon-like peptide. It's a protein in the gut, basically. It's a protein that's circulating in your body. And when you block that hormone, it slows down gastric emptying. It slows down how the stomach processes food. It has several other effects around the body as well, but the main one seems to be that it really slows down how the stomach processes food. And so when you do that, you absorb your food more slowly, and you tend to feel full with eating less and eating less often. And so these GLP-1 medications were developed over 25 years ago. They're not new by any means. They've been around for quite a while.
Oh, wow.
But they were developed as a way of lowering blood sugars. So these were developed as a treatment for diabetes, and they were very effective for that. The initial trials for people with diabetes showed that these medications improved blood sugars and improved glycemic control in people with diabetes. They did note in the trials, though, that people seemed to lose some weight on the medications. And with the weight loss came improvements in blood pressure, improvements in cholesterol, as well as improvements in blood sugars. People were then able to be a little more active, and it seemed over time that it improved their cardiovascular health. So now over the last decade or so, the trials have really moved towards not necessarily studying them for diabetes, but more for just improving overall cardiovascular health, including in people without diabetes. And so now the recent studies have had people that just have baseline cardiovascular risk that's elevated. And sure enough, as they take the medication, their weight comes down and their blood sugars come down a little bit and their blood pressure comes down and their triglycerides get better. They seem to just improve cardiovascular health across the board. And so now people are using them for cardiovascular health improvements with good success. In the trials, very clearly, the people that were randomized to the actual medication, over time, they had less heart attacks and less strokes. Now, we do see it's being used, for cosmetic weight loss in pretty healthy people. That's really not the ideal use at all. These are medications to improve cardiovascular health in people that are at elevated cardiovascular risk, both with and without diabetes. And so they're definitely one of the tools we have available now to help decrease cardiovascular risk and improve cardiovascular health. Main risks are gastrointestinal side effects. So because you're slowing down gastric emptying, if you slow it down too much, people don't feel very well. They can feel nauseous and bloated and have abdominal pain. And so we have to be very careful with the dosing. We have a program at our institute here that uses a pharmacist to kind of talk to the patient every couple of weeks. We're very careful with the dose adjustments. If you start at a very low dose and slowly work your way up, over 90% of the people in our program have tolerated them fine. And so they can be a very safe medication. Some people have enough gastrointestinal side effects that they do have to stop them. And so that definitely can happen on occasion. But in terms of improving cardiovascular health, they're one of the most important tools that we have right now.
Yeah, and they're so popular, so I'm so glad that you were able to address that. And before I go on to the next live question, I'm just going to make a quick programming note because some people are writing in if this is being live streamed. Yes, this is a live event and a live broadcast. So glad that you're all here. It's just that our pictures are not live on video, but this is an entirely live conversation, so please keep your questions coming in. Let's go into another live call that's coming in from Barbara. And Barbara, please go ahead with your question.
Yes, hello. I was asking, what is the best time after eating to check the blood sugar? I hear anywhere from 1 hour to 2 hours.
Yeah, it's a good question. And you're right, it is anywhere from 1 hour to 2 hours. The spike in the blood sugars after a meal are directly related to what meal was consumed, so the type of food a person ate, but also their metabolic rate, how their stomach processes food, which is directly related to their risk for diabetes. And so anywhere from 1 to 2 hours is pretty consistent. And as far as being the optimal time, we want it to be consistent after each meal, though. So if one time it's an hour, the next time it's 2 hours, then we do see some fluctuations, which might be just related to time. And so it can be anywhere from an hour to 2 hours, but we want it to be pretty consistent in that time interval, that the patient does it kind of at the same time each meal, just so we get a good idea of how they're responding.
Absolutely. And Barbara, thank you so much for that question. Might I also add that some people are checking their blood sugars with finger sticks, and some people are using continuous glucose monitors, which is checking your blood sugars throughout the day, and also using the finger sticks as well. So if that's not a conversation that you've had recently with your healthcare provider, your physician, your diabetes educator, your certified diabetes care and education specialist, please bring it up with them again, because as things change over time and as you get older and your health status might change, that might increase or decrease accordingly. And if some of the medications that we were just talking about have been implemented to treat heart disease, heart failure, or you're on a GLP-1 medication, it may change as well, right? So that's something to consider as well. Let's take one of these questions that we're getting so many great questions. So this is a great question that's coming online from Jenny, and Jenny says, this is, I was speaking of CGMs. I wear a CGM, and I notice that my glucose spikes when I eat starchy carbohydrates. So how should I adjust my diet so it doesn't spike as high? That's from Jenny.
Yeah, great question. And we know very clearly one of the best ways to have a spike in blood sugars is to take in simple carbohydrates. So processed carbohydrates, so your white bread and your white rice and your white pasta and chips and cookies and crackers and sugar-sweetened beverages, your body can turn those all into blood sugar really, really quickly. And so we know very clearly that people that consume less of those tend to have less blood sugar spikes, but also that they replace it with complex carbohydrates and also fruits and vegetables and healthy fats and healthy proteins. And so, sometimes I think we get a little too detailed and, we say this is the perfect diet for diabetes and this is the perfect diet for kidney disease and all these different diets. It's all pretty much the same diet for overall health. We want to be high in fruits and vegetables. We want to be high in healthy fats like olive oil and nuts and seeds and avocados. We want to be high in healthy proteins. And we really want to cut out processed carbohydrates and processed meats. Those are the main things to eliminate. And so, yeah, the less you have of those in your diet, the more healthy stuff you have in your diet, the better the blood sugars will be.
What a great response. Absolutely. And just a little plug for something that I always speak about also is you can ask your provider for a referral to a registered dietitian nutritionist who's also a certified diabetes care and education specialist that can help you with an individualized meal plan as well. So those questions are important to ask and to get updated throughout your diabetes journey and your lifestyle journey. Sometimes things change and you need to have your nutrition plan changed as well. So thank you for that as well. We have another great question coming.
Susan,
Yep.
Can I interject with a quick question?
Of course.
What do you think about continuous blood sugar monitoring in people with prediabetes or early onset type 2 diabetes?
That's a great question also. I think it's very important for people who are not going to be overwhelmed with the data. So data is only as good when you receive it, what you're going to do with it. So if somebody is using a device who does not have diabetes or they have pre-diabetes and a family history of diabetes and they're monitoring their blood sugar and using a CGM, and that's an important conversation because that will not be covered by your insurance, but there are several companies that are making them that you can get without a prescription and use over the counter. So we'll put that out there as well. For some people, I've seen it really, really help to understand what you're eating and your nutrition. But if getting too much information all at once is overwhelming and you're not sure what to do with that data, I've seen people kind of become overwhelmed with using it. So if you're using it in the right way and it can help you learn how your physical activity is affecting your blood sugar, how what you're eating is affecting your blood sugar, how your sleeping and your stress response affects your blood sugar, then I think it's a great idea. How about you? What do you think about that?
Yeah, it's a good question, or it's a great answer. And it's a question that I struggle with because I see both sides. I definitely have patients where the positive feedback has helped them kind of make better decisions for their diet and for their exercise. But I also definitely have patients where they're too busy monitoring their health in order to have time to be healthy.
Exactly.
And so we don't want too much information necessarily all the time. And so at the end of the day, what you eat and how active you are and how you take care of yourself, that's really what matters here. We can check all the blood sugars we want, but if we don't make any changes, then nothing's really going to change. And so we don't want to monitor things too much in certain situations.
We are exactly on the same page. And when you become kind of looking at it all the time and you're not really understanding what you're seeing, or it's becoming very overwhelming. And again, it's taking into account not only what you're eating and how your physical activity, but if your sleep habits are off and your sleep hygiene is not great, all of those things will address it. So yeah, we're on the same page with that exactly. Let's go to another live question. So we're going to take this question from Dora. Dora, please go ahead with your question.
Yes. Do you hear me?
I do.
Okay. I was diagnosed a few months ago with mild pulmonary hypertension. And my thing was, for the last 20-some years, I've had shortness of breath, and they couldn't find why. I've had all kind of tests, and they had said that, I had, had asthma, which I do take all kind of asthma medicine. But my thing is, the doctor had put me on 2 blood pressure medicines. He changed my 2. I was already on 2 blood pressure medicine, metoprolol, Target, and they taken me off of that and put me on metoprolol with Aspirin or something like that. But anyway, because I was having irregular heartbeats about a couple of weeks ago. So my thing is, with my sugar level is like now 6.7 in the last, I said in the last 3 months. It's gone from 6.0 to 6.7. Do you think that this fluid, he told me that this particular medicine might cause fluid. Doesn't seem like I'm on the Ozempic. And I went from the 0.5 up until the 1.0 about 2 weeks ago. So do you think that some of this medication is causing my sugar diabetes to rise?
Thank you for your question, Dora.
Yeah, it's a very good question. And as always, these things are always complicated, right? There's always multiple things going on. And so, having a finding of mild pulmonary hypertension, so a slight increase in the blood pressure and the blood flow to the lungs, is a pretty common finding. We definitely see that, especially in the setting of diabetes and asthma and a few other things like that. And so that typically is in response to what's been going on, not the cause of what's going on. So I wouldn't think that that'd be a major contributor to shortness of breath, though if it increases, it definitely can. So it's something we'd want to keep an eye on. But the idea that that would definitely be the main cause here, I think, is less likely. As far as Ozempic goes, or semaglutide is the name of that medication, that is one of those GLP-1 medications. Typically, if anything, they help blood sugars over time, but sometimes it can take a little bit. So if you're just on the early doses, it might not have a bigger effect until you get to the more regular doses. And so, yeah, I wouldn't expect the blood sugars to go up from that over time. And yeah, for the shortness of breath and exertion, it can be a little frustrating sometimes, because in medicine, we're really good at telling you what you don't have. We're not so good at telling you what you have sometimes. And so quite often these things end up being, again, kind of multifactorial, where with diabetes and a little bit of higher blood pressure in the lungs and maybe a little bit of fluid retention and a little bit of higher blood pressure, those can all lead to a little bit of shortness of breath over time. And so, yeah, the treatment plan is still the same, though. It's a healthy diet and plenty of physical activity, and then using the medications that your cardiologist or primary care provider gives you.
That was a great question and a fantastic response. And it leads me to a question, and I think this is so important for so many of our listeners to hear. When we have these type of concerns, and especially concerns on how to reduce our risk of heart disease, and if we do have cardiovascular disease and diabetes, what we should do next, how do we bring up this discussion with our doctors? What is the best way to kind of approach the conversation of prevention of heart disease, or to reduce our risk factors with heart disease when we're living with diabetes? Because sometimes we're afraid to bring that up in a conversation. How do we first address that with our doctors?
Yeah, I think it's perfectly okay to ask the question. Say, what exactly is my cardiovascular risk and what can I do about it? If we go back to the beginning of cardiology, some of the initial research studies in cardiology, like the Framingham Heart Study was one of the first ones back in the 1960s. The main take home from those studies was that cardiovascular disease is multifactorial. It's not just cholesterol that causes plaques to build up. It's your cholesterol plus your blood pressure plus your blood sugars plus what you eat and how active you are. It's a complicated system. And so to assess risk, we have to look at all those different risk factors. And to try and lower that risk, we have to lower as many of those risk factors as we can. And so to ask this question to your doctor, okay, I know we are addressing my diabetes. What about my overall risk? It's a very valid question and one that we definitely should be addressing.
Absolutely. Let's take another question live. This question comes from Mia, and Mia is calling in from Tampa.
Hi, doctor. I have a question. Can uncontrolled diabetes for like 6 to 7 months cause congestive heart failure? And what is the life expectancy for congestive heart failure?
Yeah, very good question. So we do know very clearly that diabetes is a risk factor for congestive heart failure, without a doubt. Typically, it's a chronic process. So typically it takes years and years and years of diabetes, just like it takes years and years of other risk factors. And so to have, diabetes that was poorly controlled for less than a year does increase cardiovascular risk some, but typically not a huge amount. And so, we know very clearly these risk factors take years and years to develop, and they take often years to have their impact. That also speaks to the importance of duration of treatment. If we look at treatment of these risk factors, the longer you treat them, the better people do. The earlier people intervene, the better people do. So if we take people with poorly controlled diabetes, the longer we treat it, the more benefit there is. And so sometimes people say, well, can I just wait till 5 or 10 years now and then start treating that risk factor? The earlier we treat it, the better it goes. It's like quitting smoking when you're 30 versus when you're 70. Those have different outcomes associated with them. And so the earlier we can take that risk factor off the table, the more benefit there is.
Early is always better. Yes.
Yeah, sorry. The second part of your question, life expectancy really depends on a lot of other factors. Heart failure used to have a really poor prognosis. We weren't very good at treating it. We've gotten a lot better over time. And so it still definitely can have complications. It's not something we want people to have by any means. But with effective control of the risk factors and with effective heart failure therapies, we see people that do well for years and years.
That is the good news. And that's another reason to bring up, if you have these concerns, even before you go for any of your appointments in person or even over a telehealth appointment, send a note in advance of your concerns. You can put it in the patient portal, call ahead if that's appropriate for your practice. But these questions are so important, and we're so grateful for Dr. Maduma to be able to answer these questions today. Continue to have these discussions with your healthcare providers. It's so important. Let's go to another question that's coming in from Chris, and Chris is calling us from Indiana. Chris, please go ahead with your question. Chris?
53. Should I be on a statin?
Chris, can you start over? We missed the first part of that question.
Oh, sure. So I'm a type 2 diabetic. I was diagnosed about a year ago, and I have a history of hypertension. Since I am diabetic, should I be on a statin?
Yeah, great question. One that comes up frequently. And pretty much nobody comes in a clinic and says, can I please start a cholesterol pill? Most people come in and say, I've heard some things kind of both ways about this. I'm not sure I want to take one. What do you think? And I would say that the whole statin story is one of the more complicated stories in all of medicine. And it's an area where the perception and the reality are pretty far apart. The problem is one of the first statins back in the 1990s, rosuvastatin, was a medication that wasn't monitored very well, and it had some pretty serious side effects in some people. And it wasn't picked up on right away. And finally, when the data came out, it caused a big stir and kind of put a dark cloud over the statins, so to speak. But because of that, the newer ones, which really aren't that new anymore, they were put through these huge safety trials where half the people get a medication, half the people get a placebo pill. You follow them for a number of years and see how they do. And in those trials, the safety data actually looked quite great. For rosuvastatin, which used to be Crestor, we have trials out over 20 years in several different studies. And people on a full dose for 20 years straight, we don't see a lot in way of harm. And so the FDA is actually looking at moving lower dose rosuvastatin over the counter. And so we have really good safety data for these medications. And importantly, they lower LDL cholesterol. They lower your bad cholesterol quite a bit. They're pretty effective at doing that. I think sometimes people think that the majority of their cholesterol comes from their diet. About 80% of your cholesterol is made by your liver, and that's largely genetically set. So only a small portion of your cholesterol comes from what you eat. And so through lifestyle, you can definitely affect your cholesterol levels, but quite often not to the level that we want it to. We want it to go down further if we can. And so in the trials that have studied use of a statin in people with diabetes, there was a very clear reduction in cardiovascular risk. There was less heart attacks, less strokes, less bypasses and stents, all those interventions that we don't want. And so the guidelines have gotten pretty aggressive to say that if you have type 2 diabetes, you should at least think about taking a low dose of a statin. I would agree with that. I think the data support that. And we also have data now that they're quite safe. Again, this is a situation where we don't want trade-offs. If we lower your cholesterol and make you feel rotten, that's not success in any way. We don't want to give you anything that's toxic. That doesn't make any sense. And so for low dose for rosuvastatin and for a few of the other statins, we have really good safety data at this point. And so, yeah, a low dose of a statin in people with type 2 diabetes is a pretty reasonable thing to consider.
Do you think that rosuvastatin or the generic Crestor will go in low dosages over the counter? That's very interesting.
Yeah, I honestly, I think we have the data to support it. I think it'd be a reasonable thing to do. These kind of questions like this tend to take a while. Everybody kind of throws in their opinion and we start arguing about things. And so I wouldn't be surprised if it takes a while. But I think at some point it probably will happen.
Very, very interesting. We have a question coming in from Ellen, who's sending this question online. What role does aspirin have in helping with heart disease or helping prevent heart disease?
Yeah, it's a very good question. And this one is a little bit trickier. When most people come into clinic and say, I'm thinking about starting a low-dose statin, I say, I think that's a really good idea. For the aspirin, it's more complex, more complicated. So aspirin is an antiplatelet medication. And we know that part of the heart attack and part of the stroke process involves a clot forming at a ruptured plaque. And so on the aspirin, that clot is less likely to form. And so we do see less heart attacks and less strokes when people take a daily aspirin for prevention. The issue is that because it's an antiplatelet, it has a bleeding risk associated with it. It's not really traumatic bleeding, so it's not bleeding from falls. It's mainly GI bleeding. So an ulcer in the stomach or a polyp in the colon, on a bad day, it can become irritated and it's more likely to bleed on the aspirin. And so when aspirin was studied 30 or 40 years ago, it looked to be pretty beneficial. Now that was in the setting of not a lot of good other treatments for cardiovascular risk, right? So we didn't have very good cholesterol meds. We didn't have very good diabetes interventions. There was a lot more smoking and secondhand smoke. And so there just were a lot more heart attacks at the time. And so there was more to be gained by taking the aspirin. Now when the studies have been redone in the modern era, the benefit of the aspirin has gotten smaller. There's less heart attacks to be avoided in the modern era. And so there's still a benefit, it's just small. And there's the bleeding risk, which is small as well. And so we're looking at 1,000 people and we're avoiding 4 or 5 heart attacks, but we're causing 4 or 5 major bleeds. Is that really worth it? And so the guidelines have really settled on when you're thinking about taking an aspirin, you need to think about your overall level of cardiovascular risk. And so if your level is elevated, then it's reasonable to take the baby aspirin. If you're not high risk, then it's probably not worth it. It doesn't make a ton of sense. For people with diabetes, they typically are at enough risk where we do think about it. So quite often we'll do it. However, if they have any issues with any sort of bleeding, whether they've had a prior GI bleed, or if they have easy bruising, we're pretty quick to stop that aspirin if we need to. And one of the things we do see is that the bleeding risk with this really varies by age. It's mainly people in their 70s and 80s and 90s that are having a lot of the bleeding issues. And so once they get above age 70, we're not too aggressive with the aspirin quite often. There's quite a few people will stop it in. It's definitely not mandatory at that state.
That's really changed over the years. So thank you so much. That's very great, up-to-date information. Appreciate it. We have a question coming in from Erica, and Erica sent us a great question online. Can you speak about the considerations for Black women living with diabetes and hypertension and health disparities that might affect treatment options?
Yeah, it's a great question, and it's a complicated answer that's been getting a lot of attention lately. You know, whether or not we should have race as a risk factor, ethnicity as a risk factor, is really complex because people live in different areas and they're exposed to different environmental factors. And so quite often it's not the race, it's the environment that's affecting things. And so we do definitely see disparities in places of lower income areas where they have less access to quality food. It's much harder to be physically active. And so those all do impact cardiovascular risk. The newer guidelines have gotten a lot better at addressing that, saying we should factor that into our decision making sometimes when we're seeing patients of color and other minorities. And so it's something that we're definitely factoring in more and more. How to adequately do it is tricky. It's a pretty complicated system. And so in general, the treatments have similar, benefit across the spectrum of men and women and multiple ethnicities. For a while, women and cardiovascular disease is a good example. For a while there, most of the initial statin trials and a lot of the initial lipid-lowering therapy trials included very, very few women. And so that was really tragic in that we had one gender that we thought benefited, but we really didn't know about the other gender. And so now more recently, they've done a really good job of increasing the number of women in these trials. And we're seeing pretty similar benefits. It's really beneficial across the board, whether that's treating blood pressure or treating cholesterol or treating diabetes. And so we can say with confidence that when it comes to gender disparities, that we're doing a pretty good job at addressing that now. They're working more on the racial part of it as well. We're including multiple different races in these trials. And at least thus far, we've seen pretty consistent benefits across the groups. And so we don't treat people too differently at this point. I think all the interventions that we have pretty equal benefit across gender and across race.
Thank you so much for that. Let's take another live question, and this question is coming from Adrian, and Adrian is calling us from Pensacola, Florida. Adrian, please go ahead with your question.
Hello. My first question is, what are the foods best for diabetes and for the heart?
Yeah, it's a great question. It's one you think we'd be able to answer really, really well, but we haven't done a great job with nutritional research for cardiovascular disease, not as well as what we should have done at least. And so we do have a good idea of some themes in terms of, if you look around the planet, there's a lot of people eating a lot of different ways that seem to be relatively healthy. So the idea that there's just one diet you have to follow and that's the perfect diet, I don't think that's the case at all. However, the themes are pretty consistent, and the themes I would break it down to 4 things. I would say, number one, we do not want it to be a low-fat diet. We have really good evidence at this point that these healthy fats are incredibly important for us. So olive oil and nuts and seeds and avocados and fish, these things are full of fat and they're fantastic for you. And so we do want to be a little careful with saturated fat, so your red meat and your dairy. I don't think those have to be banned from your diet, but those should be limited in your diet, whereas the healthy fats we should definitely include if we can. Second part is that it should probably be a mostly plant-based diet. So the more fruits and vegetables that we eat, the better people do. That's pretty clear. The more nuts and seeds, the more avocados, again, the more fruits and vegetables people eat, the better they do overall. I don't think it has to be an all plant-based diet. You don't have to be vegetarian or vegan, but the more fruits and vegetables you can include, the better people do. And the third thing is, like we talked about earlier, we really want to limit the processed intake of processed foods. So your processed carbohydrates and your processed meats, those things clearly are not healthy for us. They increase risk for diabetes as well as heart disease. And so the more we can exclude those from their diet, the better people are going to do. And quite often I'll have people, they'll ask me, in the grocery store, how much of this ingredient should I have or how much of that ingredient? And my answer very clearly is the vast majority of things you buy at the grocery store should not have an ingredient list. They should just be a single ingredient. So if you're getting fruits and vegetables and salmon and a little bit of steak and olive oil and milk, you're doing great. If it's coming out of a package or a can of the drive-thru, that's when we tend to get in trouble. And then finally, we really don't have a ton of evidence that we should be taking a lot of supplements. We've got pretty good research now on a multivitamin and fish oil and all these different ones. We haven't really been able to see an improvement in cardiovascular health. And so the theme just continues to be, it's way better to simply eat the real thing. It's way better to eat fruits and vegetables and fish, include those in our diet, and not take any food in pill form.
That's really great advice. And might I add, with a lot of the cost of fresh vegetables becoming very high, very expensive for most of us, don't forget about frozen vegetables. So if you can't get, for example, the great healthy cruciferous vegetables fresh, like cauliflower, broccoli, Brussels sprouts, these things are also available in frozen form, and those are very healthy as well. So don't despair, and you can keep them in your freezer and use them when you want them, and more cost effective at times. So try to keep that in mind when you're meal planning and shopping as well. That was great advice. So let's go to another live question. This one is from Laura Lee, and Laura Lee is calling us from Utah. We have so many great people joining today with excellent questions. Thank you so much. Laura Lee, please go ahead with your question.
I started with type 2 diabetes, and now I'm on insulin. Could I still take a GLP-1 medication along with the insulin?
Yeah, very good question. And you can. They can be used together very clearly. And so, yeah, we do see some people that start with type 2 diabetes that is not insulin dependent, and it just progresses over time to the point where they do need insulin. And so in that setting, we can use the other medications with the insulin. Now, sometimes if the medications are very effective, then the insulin needs to be adjusted. And so you definitely could do that under the watch of your endocrinologist or your primary care provider. But you would have to keep a close eye on those blood sugars, because if we add in an effective medication for diabetes, then we probably will need to adjust the insulin. And so it can be done. We just have to do so a little carefully.
And that's where we have to always stay in touch and let our healthcare providers, our physicians, whoever our providers are, let them know what is going on. You don't have to wait till your next appointment if you're having a change in your blood sugars and that's not being shared all the time. Make sure that they know what's going on because those adjustments are so important. Thank you for that. Great question coming in online from Renee. Renee asked, I took a GLP-1 medication for about 6 months and got gallstones and then had to stop taking it. I am a heart attack survivor of 2 years and have type 2 diabetes. I lost 57 pounds and my A1C is 5.6, but I wonder if I will be able to take the GLP-1 again.
Yeah, very good question. And again, when we talk about the safety of these medications, it's really important to look at the trial data because that's by far the most informative because there's a lot of things that happen in life. And so we're always left kind of guessing, is this the medication or not? In this case, it probably was the medication that contributed. What we see that with really effective weight loss, we do see more likelihood of gallstones. And so we see this actually in the bariatric surgery trials, where when they do intervention there and they lose a lot of weight, they can get some gallstones sometimes. And then with other interventions that make people lose a lot of weight. And so it's probably related to the medication. It doesn't come with a ton of risk. And so if I were seeing you in clinic, I would say it'd probably be okay to go back on the GLP-1. You'll have to have that conversation with your provider and see what they think. But it is probably related to the medication, but I don't think that's an exclusion of moving forward with the medication. It was working very effectively and people were feeling good on it. You know, is there a risk of recurrent gallstones? A little bit, but with that much weight loss, probably not as much moving forward. That being said, it's risk versus benefits, right? So for that little bit of risk for all the benefit you're having, if it were up to me, I'd probably say, let's take that little bit of risk. And so it's something that not an easy decision necessarily, but one that I think is reasonable.
Absolutely. Mary is asking a great question also online. Is there any cardiac testing that's recommended if you have prediabetes and you're taking no meds?
Yeah, that's a very good question. That's one of my main areas of research. And there's no perfect answer here because there's still, we could use a little more data on some of these things. But in terms of assessing cardiovascular risk, like we talked about earlier, it's very clearly a multifactorial process, right? There's lots of different risk factors to factor in. Some of these risk factors are kind of hard to measure, like stress and genetics and a few of these other things. And so we know pretty clearly that me sitting across the room from a patient and telling him what the risk is not as accurate as what we'd like it to be. We can get kind of in the ballpark, but not as good as what we want to be. And so the question has always been, what other testing should people consider? And, if this were 30 years ago, we'd do a stress test quite often, say, let's put you on the treadmill and see how your heart performs. And no, there's nothing wrong with stress tests. They're really good in symptomatic patients. If we're trying to figure out if some chest pain is coming from the heart or not, they're not a very good preventive tool. They don't come with a warranty saying, oh, if you have a normal stress test, there's nothing that can happen in the next year. It's not really how it works necessarily. And so from my standpoint, I think the research is most in favor of something called a coronary artery calcium score or a heart scan. It's basically a CT picture of the heart. It's like a mammogram of the heart is the way to think about it. As plaques develop in the arteries that feed the heart, those plaques tend to calcify over time. They get calcified in the shell of the plaque. Calcium's not the bad part of the plaque, but the calcium does happen. And that shows up really well on an x-ray like bone does. And so you can take a CT picture of the heart and see how much calcium is there. You get a calcium score. And it turns out that's a pretty good marker of how much plaque is there. And how much plaque is there is really what correlates with future risk. And so for somebody with prediabetes or somebody with a bad family history, a little bit of high cholesterol, where we're not quite sure about the level of risk, the calcium score to help kind of refine the risk and then make some decisions from there, I think is really helpful.
Absolutely. Thank you for another great response. We're getting such excellent feedback. We really appreciate it. We have another question live coming in from Richard, and Richard is calling from New York City. Richard, please go ahead with your question.
Oh, I didn't know it was coming on live. Actually, I'm from New York State, but yes, a few years ago, I was on an oral med. I don't know if I should name it, but you let me know. In which I got a bout of acute pancreatitis. Now, I was told later, and this was, like I say, 5-6 years ago. This was before all of the Wegovy's and the weight loss, drugs. I was told that there were really no other meds other than metformin, glipizide, or insulin that I could take. I'm type 2, that didn't have that pancreatitis risk. Is that true? And can you recommend anything else I could add on to, because I do need to get into better control, if I can add to my regimen? Yeah.
That's a very good question. It's somewhat of a difficult situation. So we do see with the medications that act via the pancreas or the liver for diabetes, there is this slight risk of pancreatitis. And the problem with pancreatitis is that it can be very serious. Episodes of pancreatitis can be life-threatening at times. And so we want to be very careful in mitigating that risk of pancreatitis. For the oral meds that could do that, we did see an increase in risk. For the GLP-1s, they've been tracking them pretty closely. There might be a pancreatitis risk, but if it is, it's quite low. There's no matter what we're doing, we're taking some risk here, right? And so if we try the medication, there is a slight risk of pancreatitis. But also we know off the medication with poorly controlled diabetes, the risk of cardiovascular disease and other stuff is elevated a fair amount. And so in terms of risk versus benefits, I would be tempted to try the GLP-1 at a low dose and see how it goes. That's not a perfect answer, but there's not a perfect answer here. No matter which route we go, we're taking a little bit of risk. And so in my setting and from the data that we have, I'd say this is a pretty low risk situation for pancreatitis, but it's not zero risk. And so that's what makes the decisions hard. But I think a trial of the GLP-1 could definitely be considered.
That's great. And that's such a hard situation. So one that's a little bit more challenging to navigate for sure. Dee is asking a question. I don't think that we've touched upon this yet today. So Dee's question is, what is losartan and why did my PCP prescribe it, although we are not really sure, to protect my kidneys? So it's what is losartan and why did my PCP prescribe it to protect my kidneys?
Yep. So losartan is it's an ARB, it's called. It's one of the main classes of blood pressure medications that we have. So at this point, we really have three main classes of blood pressure pills that have been shown to be very safe and work relatively effectively, including the class that losartan is in. And that class that losartan is in is a little bit unique in that it seems like in people with diabetes, it does protect their kidney function over time. Having better blood pressure over a period of years does seem to affect kidney function in ways that are positive. And we do see that people that have diabetes, one of the main things they're at risk for, in addition to cardiovascular disease, is kidney disease. And so whatever we can do to protect the kidneys in that setting, we want to do, provided that we can do it safely. And losartan is a very safe medication. That's a very reasonable addition in that setting.
Yes, very, very important. And again, if anybody has questions about their specific medications, please reach out to your physician and ask them exactly what the medication is, or to your pharmacist. Pharmacists are a fantastic resource in these situations as well. And before we continue on with towards the end of the program, can we talk a little bit more about exercise? Because I'm getting a lot of questions about exercise. Sometimes I don't even use the word exercise. I use physical activity. But is aerobic exercise recommended, resistance exercise recommended, or both? And what do you usually suggest to the people that seek your guidance on physical activity and exercise?
Yeah, great question. And really probably one of the most, if not the most important questions that we have here in terms of the importance of the benefit. And the benefit is huge. And so, to me, it's a little bit contrasting. For nutritional science, we are really, like I said, craving more data, more research to kind of help us understand what matters and what doesn't matter and what's healthy and what's not. For physical activity research, it's almost kind of boring because it all seems to work. So whether it's walking or jogging or swimming or yoga or pickleball, it all seems to have benefit. And the more you do, the better it is. And even minimal amounts are helpful. And so what I tell people is try and be as active as they can be. There's not very many people where I put a ton of restrictions on them. Again, like I said before, we've learned this the hard way. Having people rest and take it easy because they have some sort of cardiovascular risk is not the best recommendation. The more people do, the better they're going to do. And the broader mix of things they do, the better they tend to do. Because, the same activity every day seems to be a little bit harder on the joints, whereas the more they mix it up, the better people tend to do. It sure does seem like the mix of cardio plus resistance training seems to be the best, meaning something that works out the muscles as well as something that gets you huffing and puffing a little bit. And so the mixture of those two together seems to be best. The American Heart Association aims for 150 minutes a week. That's 30 minutes a day, for 5 days out of the week. So nothing too crazy. But that's very much kind of an arbitrary number. The people that do a little bit less than that or a little bit more than that do about the same. And so the more you can do, the better you're going to do. And it is one of the most important things for your cardiovascular health.
And we have another question coming in based on the GLP-1s and physical activity. If someone is taking a GLP-1 medication, should they increase their physical activity? And if so, which type?
Yeah, very good question. And it's one that I think I see kind of misconstrued in the media more than any other kind of question within this topic. And that is the role of lifestyle and GLP-1s together. I think sometimes people say, well, these medications are becoming a substitute for a healthy lifestyle. That simply is not the truth at all. That's not how this works. We know very clearly they only work effectively when they're combined with a healthy lifestyle. And so, yeah, we definitely want you to be as active as you can be while you're on the GLP-1. And again, the lifestyle part of this and the GLP-1 are additive to each other. The better people do with the lifestyle while on the GLP-1, the more weight loss they'll have, the more their diabetes will get better, the more they'll improve overall. And so, yeah, we definitely don't want to restrict physical activity in any way when they're on a GLP-1. And in fact, we'd encourage it as much as they can do. As far as what type of physical activity, again, I don't think I'd give a specific answer where it has to be a certain type. We do see concern that has been raised that over time, there might be loss of muscle mass in people on GLP-1s where you're losing fat but also muscle. And there's some evidence to support that. That being said, for the longer-term data in people with diabetes, where these medications have been used for well over 15 years, we haven't seen a ton of huge muscle mass losses or anything that kind of deteriorated from that in terms of long-term side effects. And so I'm not too concerned about that. That being said, again, some sort of resistance training as part of the exercise routine would be a good idea, whether you're on a GLP-1 or not.
And to do the exercise, the physical activity that you enjoy, people will say to me, I don't like going to the gym. I don't like using a treadmill. Do you like to dance? Do you like to walk? Do something that you enjoy. Physical activity doesn't have to be, sometimes the exercise word is like this E word that people don't want to do. Do what you enjoy, move. And sometimes walking with a buddy, somebody else who you want to walk with, it gives accountability to both of you, and it's a very positive thing to do.
Yeah, that's a great point. And I'd say culturally, we've learned a little bit as well, right? So there are definitely some other countries where nobody exercises, but they're incredibly physically active, right? Where they don't have a time, that's not part of their workout routine, but yet they're active and hiking and doing stuff that are kind of busy all day long. And that seems to have quite a bit of benefit as well. And so it's not like it has to be a focused time of exercise. It's just being active in some way. It all seems to have benefit.
Absolutely. So in taking all the excellent information that we've spoken about so far today, please remember to speak to your doctor or your healthcare provider about your health goals. And if you have any questions about your diabetes, your heart health, or any interest in new diabetes technology, please speak to your physician or your healthcare provider or your diabetes care and education specialist. Talk with them about your lifestyle options to reduce the risk of heart disease and high blood pressure. And remember to discuss your blood glucose and lipid targets with your healthcare provider. Please remember at the end of today's presentation, at the conclusion of our Q&A segment, we're going to have a very short Q&A, a very short survey, which we really appreciate. It'll take less than 5 minutes for you to complete because your feedback is so important to us, and it helps us to shape future events. You're asking so many fantastic questions today. Dr. Meduma, please, what are your final key takeaways from today? You've shared incredible information. Is there anything else that you'd like to share with our attendees, who, by the way, asked fantastic questions throughout today's event?
Yes, I would agree. There were great questions. We kind of covered all the major topics. I think at the end of the day, sometimes especially for people with diabetes, where, we say you should probably be on a cholesterol pill and a blood pressure pill and on diabetes pills, that burden feels like it makes them feel sick. Right? It makes it feel like, oh man, I'm on all these medications because I'm so sick. And I get the feeling for that, and we need to be sensitive to that. That being said, that's not the goal of these medications at all. These medications are meant to keep you healthy. And so for most people, especially early in the course of type 2 diabetes, they are relatively healthy, and the goal is to keep them that way. And so we know the best way to do that is the complement of the healthy lifestyle with certain preventive medications. So that combo really is what works the best. And so we don't want to give them and put this in the state of, oh yeah, you're a very sick person, so you need all these medications. You're simply a healthy person who are trying to keep healthy.
That's great advice. Thank you again so much for your time today and sharing all this information during Heart Health Month. We're so pleased that you were with us. Everybody, remember to talk to your doctor and members of your healthcare team about your risk of heart disease, heart failure, stroke, and kidney disease. And please remember to speak to your doctor or healthcare provider about getting a referral for diabetes self-management, education, and support. Remember to go to NoDiabetesByHeart.org and sign up for our newsletter and register for our next events at diabetes.org/experts. That's diabetes.org/experts, where you can see any of our past events live as well. Call 1-800-DIABETES, that's 1-800-342-2383, or email askada@diabetes.org to request a digital copy of How to Thrive resource that can help you on your diabetes journey. And I just cut you off. Were you going to say something? I'm so sorry.
No, I just said it was my pleasure. Happy to do it.
Okay, thank you so much. I appreciate it. Thank you for all your great questions and everybody who wrote in with those fantastic questions. And I'm so sorry if we weren't able to get to all of them. It was a really popular and lively Q&A event. And if you have any questions, please contact us again at askada@diabetes.org or call 1-800-342-2383, 1-800-DIABETES. Today's event, as well as all previous events, again, are on demand at diabetes.org/experts. Thank you so much for joining us today. And on behalf of us and the ADA team, we want to thank you for joining us today. Please stay tuned for our brief survey. And if you have any questions specifically about this event, please go to askada@diabetes.org. And in the title, please include Ask the Experts Q&A in your subject line. Thank you for joining us today. Let's get started with our brief survey, and I really appreciate everyone who's staying online for this. Thanks for participating in today's event, and remember that all of your responses will be confidential. Question number 1. This event met my expectations today. This event met my expectations today. For yes, please press 1. For no, please press 2. If you're unsure, please press 3. Question 1. This event met my expectations today. For yes, please press 1. For no, press 2. For yes, please press 3. If you feel you can use more support for managing your diabetes, please check out the diabetes.org website, the ADA website. There are so many links to information that could help you with your diabetes journey. If you navigate around the site, you'll see incredible amounts of information. Let's move on to question 2. Question number 2. I will attend another Ask the Expert event. Question 2. I will attend another Ask the Expert event. For yes, please press 1. For no, please press 2. And if you're unsure, please press 3. Question 2. I will attend another Ask the Expert event. For yes, press 1. For no, press 2. And if you're unsure, press 3. Looking to find out more about diabetes and technology? Check out the Diabetes Technology Guide at the ADA site, diabetes.org. That's the Diabetes Technology Guide. Question number 3. This event improved my knowledge of the connection between diabetes and heart health. Question 3. This event improved my knowledge of the connection between diabetes and heart health. For yes, press 1. For no, press 2. And if you're unsure, press 3. Question 3. This event improved my knowledge of the connection between diabetes and heart health. For yes, press 1. For no, press 2. And if you're unsure, press 3. Did you know that there were approximately 38 million people living with diabetes? So you are not alone. If you're looking for peer support, the ADA offers peer support at local and state offices, diabetes camps, online forums, and more. Please check out www.diabetes.org/community. That's www.diabetes.org/community for more information. Only a couple more questions. Question 4. I intend to use the knowledge I gained from my or my loved one's next appointment with a healthcare professional. I intend to use the knowledge I gained from my or my loved one's next appointment with a healthcare professional. For yes, please press 1. For no, please press 2. And if you're unsure, press 3. I intend to use the knowledge I gained from my or my loved one's next appointment with a healthcare professional. This is question 4. For yes, press 1. For no, 2. And if you're unsure, press 3. Remember to check out NoDiabetesByHeart.org. That's NoDiabetesByHeart.org to learn how to take simple and practical steps to reduce your risk of heart attack, heart failure, diabetes, and kidney disease. Question 5. Before this event, I felt confident talking to a healthcare professional about the connection between diabetes and heart health for either myself or my loved one. Question 5. Before this event, I felt confident talking to a healthcare professional about the connection between diabetes and heart health for either myself and or my loved one. For yes, press 1. For no, press 2. And if you're unsure, please press 3. There's so much to know about taking care of your health and living with diabetes, and it can be overwhelming. If you want to learn more about the strategies and tools for diabetes burnout and mental health, visit diabetes.org/health-wellness-mental-health. diabetes.org/health-wellness-mental-health. One last question, and we appreciate you taking this survey. Question 6. After this event, I feel confident talking to a healthcare professional about the connection between diabetes and heart health for either myself and or my loved one. Question 6. After this event, I feel confident talking to a healthcare professional about the connection between diabetes and heart health for either myself or my loved one. For yes, please press 1. For no, 2. And if you're unsure, please press 3. We sincerely appreciate your time and look forward to engaging you on a future Ask the Expert event. Please visit diabetes.org/experts to learn more about our upcoming events. Thank you so much. I'm your host, Susan Wiener, and I really appreciate you joining today. On behalf of myself and the ADA team, thank you so much.